All right, welcome everybody to our Pathway to Adventure Council Advancement Recognition webinar. Today is August 18th, and we are very, very excited to have with us the chair of the PTAC Special Needs Committee, Ernie Fromel, and also our very special presenter today, Mr. Michael McNicholas, and we're going to be covering recognizing seizure first aid. I am definitely so excited to be a part of this course and to be able to see this. So I'm going to shut up. I'm going to turn the floor over to Michael, let him tell you about himself and guide us on this amazing discovery that we are about to learn. So Michael, the floor is yours. Thanks for being here.
Oh, thank you so much. And thank you all for joining us tonight. I really do appreciate it. I have a background with Troop 216 out here in LaGrange Highlands area, where my niece participated with the girls group when it first started with Troop 216, and I was able to be involved because I was the president of the Lions Club that sponsors the troop, and then got involved with my niece and have been very excited about all the possible ways that we can be supportive of scouting and of getting our folks out there. From a disability perspective, I am a PhD candidate in disability studies. I currently teach at Chicago State University in therapeutic recreation, which none of you have ever heard of, and that's okay. It serves people with disabilities in parks and recreation and their leisure interests. And so I'll do things like take groups out who have special needs and do things like paddling, like the Greater Maywood Paddle Program, which I'm an instructor for. Or we'll do things that are leisure and social based or Special Olympics based, et cetera, et cetera. That's a little bit of my background and where my expertise comes from. I happen to have the opportunity to work with the Epilepsy Foundation of Greater Chicago for the last 2 years as an ambassador trainer. And so that means that I went through a significant amount of training, and then they watched me give this particular presentation a number of times, critiquing me down to the very detail in order to hone my skills to bring something good to you. And that's all I really want to do tonight, is bring something good to you. So I really appreciate you having me. And I'm going to pull up the PowerPoint presentation so that everybody has an opportunity to kind of follow along, but we will take some breaks. So I'll ask that if our moderator sees any stuff in the chat, you please interrupt me and let's have some conversation too. You're all welcome to have your questions answered and comments acknowledged. So thank you again. All right, everybody should see the seizure recognition and first aid, first top slide. And Aisha Akhtar, who is the Director of Education, Epilepsy Foundation of Greater Chicago, is the author and the main person if you ever are looking for additional resources. We'll get to that a little bit later. I would be remiss if I did not say that the program's funding comes from the Centers for Disease Control and Prevention, and under a cooperative grant, and you can find more information about that if you want to contact Aisha, but it is a federally backed program. So our 5 objectives tonight are to explain seizures and epilepsy, and I'm going to try and go through a little bit quicker on that because we're not all getting degrees in disability studies or doing deep research on seizure and epilepsy. We're going to describe some different types of epilepsy and learn first aid, as well as discuss treatment options and discuss the seizure action plan. And I see there's a chat. Do we need to acknowledge that? I work closely with the TR department at Oak Forest Hospital. Let's talk after it. Woo! I'm excited about this. And I have interns for you sometime. So that would be great. So let's talk, what is a seizure? A brief excessive discharge of electrical activity in the brain alters one or more of the following. And so it's gonna affect our movement, our sensation, our behavior, speech, our awareness, maybe one of these things, maybe all of these things, depending on the type of seizure and where the electrical discharge is occurring, or the brainstorm, which is something that my friend and mentor in this program likes to refer to it as a storm in the brain, or a brainstorm. There's more than 20 different types. Not all seizures are medical emergencies. In fact, many seizures you might not even recognize. And we'll get into that a little bit more shortly. Has anyone here experienced being around someone who's had a seizure? I'm just curious before we continue to proceed. Anne has, I see that. Carrie, thank you. Okay, and Olivia, I see you. Okay. So a lot of folks have, and that's really great. Deborah, thanks for raising your hand, and that's good. And Ernie. A lot of folks have had some experience around it, and perhaps they've had some different experiences they'd like to share later on. I'd like to welcome you to please decide if you choose to share or not later on, or now if you choose, about your experiences or about questions or clarifications based on what your experiences were. Great. So let's talk about epilepsy. Chronic neurological disorder characterized by a tendency to have recurrent, which means 2 or more unprovoked seizures, i.e. there was not a specific stimulant that created a scenario where someone would have a seizure. That is common in a lot of different occurrences, things like an insulin related epileptic reaction or a traumatic injury can cause one. One of my first experiences with seizure activity was actually on a football field where someone got, unfortunately, driven into the ground, and it caused their heart to skip a beat, which caused a pulse to go to their brain, which caused them to go into a full seizure. And it was a very scary and difficult thing to kind of manage through at 17. So I wasn't really sure what to do, or 16, 17. But yeah, it was definitely something that in my experience was new and probably caused me to do a lot more research, apparently, on how to work with this. So, but there's many types of seizures. And it may also be known as seizure disorder when diagnosed by an appropriate medical professional. And by that, I mean, you have to have somebody who can read an EEG, because it can't be just diagnosed by anyone randomly, or even as different people in the medical field. So what are causes of epilepsy? For 30% of the people with epilepsy, common identifiable causes include, and of course, the most frequent one is this traumatic brain injury. That's something I described a little bit of. Stroke, brain tumor, infections in the brain, i.e. meningitis, measles, malaria, genetics. And brain injury at birth is a common congenital one. And then, of course, normal brain development. But for the remaining 70%, the cause is unknown. And so the research really definitely needs to continue and needs to continue being supported in order to have better understanding of brain activity and why it is that seizures can evolve, what environmental factors maybe even that we haven't invested time and energy to discover. So the burden of disease, let's talk about its etiology. The 65 million worldwide live with active epilepsy. In the United States, 3.4 million individuals, or 1.2% of the US population. So that means there's almost 500,000 children that are currently diagnosed or undiagnosed, but have epilepsy in the United States. 1 in 26 will develop their epilepsy in their lifetime, and in the Chicago metro area, that means about 136,000 people. And so, as you can see, this is the kind of thing where there's a likelihood that if you haven't had a chance to run into it, you may have either just missed it, or you have a great chance of running into it in the short-term future. The risk is going to be higher with people with comorbidities. Comorbidities means that there's a secondary diagnosis or a third diagnosis, but additional risk factors that may also involve seizure or epilepsy to be present in an individual. We talk about seizure types. we're really focusing on where they start in the brain. General onset seizures are going to have different starting points, but kind of all over the brain. And focal onset seizures are going to be usually located or centralized in one portion of the brain. Whether or not a person's awareness is affected is truly part of this, because if it's going to be a seizure that's affecting a particular part of the brain, it may not necessarily affect their awareness as much versus an area like, for example, in frontal cortex, where it's going to definitely affect their awareness and attentiveness to what we call executive functions. Whether or not there are other symptoms, such as movement, is affected by the location of the activity. And so this is just a quick overview, and I'm not going to describe the entirety of the brain because this is not an anatomy class. But these slides will be available if you guys want to go back and take a look at it just for your own edification. So as we get into this focal aware seizure concept, the person is awake and alert, and awareness is maintained, which means through the entire process, there's going to be some recognition of what's going on and who's talking to me, but maybe not necessarily an exchange. So focal motor, we're talking about rhythmic movements, isolated twitching of arms, face, legs, what you may see in eye movement, a quick rapid movement repetitively up and to the left, or other type of repetitive movements such as that are part of it. This is not the more dramatic seizure activity that you might have seen in the movies or might recognize as stereotypical in representation of epilepsy. Focal non-motor will involve an altered sense of smell, taste, hearing, feeling, seeing. So again, we see that all of the person's senses are activated and maybe restricted or changed, because that's also a common descriptor, is that my smell didn't go away, but the pungentness of one odor is what I remember, or et cetera, for folks who are aware, but experienced a sensory change. Same thing with hearing, feeling, seeing. Psychic symptoms such as deja vu, hallucinations, fear, feeling of fear or anxiety may also be incorporated into this focal non-motor symptomology. This particular kind of seizure is oftentimes confused with acting out by folks who don't know what they're looking at or don't recognize subtle signs, and can easily go undetected. Sometimes they'll just say it's a person who is pretending not to listen and then giving attitude when they start to become aware again a minute and a half later, or they weren't paying attention to a lesson or a description of a certain sequence of things. Let's say if you're doing a knot description and they looked like they were paying attention the whole time, but then all of a sudden they didn't understand any words you were saying. It's not because they're necessarily screwing around or being obstinate. It may be because they have some version of epilepsy, and this is part of what their symptomology looks like. We look at focal impaired awareness seizures. We're looking at the awareness being impaired. They may be confused or unable to respond. This is going to be a much more dramatic version of seizure activity, and so you'll probably recognize it a little bit. Often begins with a blank, dazed stare. We see some motor symptoms, repetitive, purposeless movements, i.e. they're doing the movement over and over again, but it has no end or true meaning to it. They may become clumsy or disoriented movements, aimless walking, picking things up, nonsensical speech, or lip smacking. May be part of what's happening. And that usually lasts somewhere between 1 and 3 minutes. They may be confused with drunkenness or drug abuse or aggressive behavior. And so it's really important to be aware that this may be seizure activity you're looking at and not necessarily, again, acting out or acting just strange or aggressive. The awareness being impaired causes that refractory period, or when someone's coming back to their awareness, to be marked with confusion. And when we're confused, sometimes we act out. when we're confused and people are in our face, it can kind of feel scary. It can kind of be the kind of experience where that loss of control will be disorienting and cause quite a reaction. And so if folks can keep that in mind as they're working with individuals who have some epilepsy, or who they think it's possible that it's not just they're acting out in negative ways, this may be one of those indicators. Anybody have questions about that or comments about something that they've seen that's related to this? Okay, not seeing anything at the moment and not being cued that there's anything in the chat. I'm moving on. General onset seizures. So we're talking about non-motor, previously called absence seizures. Symptoms can include pause in activity with a blank stare, possible lapse of awareness, possible chewing or blinking motion, quick seizure with quick recovery. This is less than 20 seconds usually. It could occur a whole bunch of times a day. And so in a given classroom setting or in a setting where you're doing instruction and let's say over a 45-minute period of time, you're trying to educate on some development of a skill, they may pick up 2 or 3 of the parts of the skill, but not the entire sequence. It's not because they weren't paying attention. It's not because they were considering other things or lost in their thoughts. It may be because they've had a seizure or 2 seizures or maybe 3 in concurrence or in succession, which caused them not to be able to put together a sequence of actions that lead to the ultimate outcome. So it's really important to be aware of that as you're beginning instruction in a group, and you know that somebody has epilepsy and you know that their type of epilepsy presents itself in non-motor, because that's going to give you the patience to and the awareness to be aware that, or to set yourself up for repeating some of the steps, giving a little bit of extra attention, doing the things that are going to go into our seizure action plan, which will be the final thing that we review before we're done tonight. I'm also going to give you a sheet that kind of goes through a sequence of things to prepare yourself and to help other leaders to be prepared. Often this type of seizure is confused with daydreaming and attention problems. Again, if it's lasting less than 20 seconds, there's disorientation. The person may come back and try to mask the daydreaming or their attention. They may not even totally be aware, depending on how young the kiddo is. And so it's really important to begin to identify that consistency that's happening, and make the parents aware of it. So motor, previously called tonic-clonic, symptoms are going to involve a hoarse cry followed by a loss of consciousness and a fall. And so you may have referred to this as grand mal in older nomenclature. Stiffening of arms and legs, and then rhythmic jerking. Shallow breathing, drool may occur, possible loss of bowel or bladder control, skin, lips, nails may turn blue when circulation is affected in this type of seizure, and the person may need to rest, or what we refer to as a refractory period, and they could have a headache and confusion afterwards for a while. If it's lasting more than 3 minutes, if we're getting into that 5-minute territory, you really do need to call for emergency, because you're going to have some intervention that's more medical professional driven. You may also find that on their medical sheets, they may disclose that no, they usually have a 3 to 5 minute seizure. Don't call until after minute 4. And that becomes the kind of thing where it's the policy of BSA and what BSA says, or the policy of a given troop and how they do medical management of this particular type of seizure. Other common generalized seizures include infantile spasms, which are just clusters of brief spasms, outstretched arms and legs. Juvenile myoclonic, sudden brief muscle jerking, and may involve the whole body or just parts of the body, and may cause a person to spill whatever they're holding or fall off of a chair. Atonic includes sudden collapse fall due to a loss of muscle tone. And after 10 seconds, 1 minute, the person will recover, regain consciousness, can stand, walk again, interact, and be generally lucid. Any questions so far before we get into first aid portion? Comments?
Michael, I've got a question.
Go ahead.
So if you're seeing someone that has had a short seizure, is that a clue that there's might be more to follow, or are these typically one and done?
That's a great question. It's very much definitely by the individual.
Okay.
I would anticipate, though, if someone's having those kind of focal short seizures, that it's plausible that they may have a variation of those that are happening in concurrence or in sequence. And that one may not necessarily predict that it will behave exactly the same as the next one. So if you had one where you saw somebody was having that focal seizure and they displayed certain symptomology, the second one may not necessarily have the same symptoms or symptom behavior. They're not exactly the same every time. So every individual who has epilepsy presents a little bit differently. They have frequencies that are different, and they may have recurrence or recurrence pattern that's different. It's really important to individualize your sense of what the person with epilepsy needs.
Thanks.
Great question, and thanks. Other folks? I will say this in my experience, but also in the literature. Folks who have more of the traditional tonic-clonic seizure pattern may have some precursory behavior, especially if they have a secondary diagnosis. You may see something that tips you off that, hey, seizure activity is going to happen soon. And that's really individualized as well. That's a pattern that you as leaders need to begin to recognize, but also a question you should be asking parents. Hey, is there any pre-seizure activity behavior that we should be looking for that might help us to be prepared when that seizure actually arrives?
Yeah, I think, Michael, there's two instances that I experienced. One was with a group of scouts, and we're walking through the woods, and the sun is shining through the trees, giving kind of a strobe effect. And we didn't know this kid had what we called at that time petit mal. And the first time we discovered that there was something wrong is when we stopped walking and he kept going. Then he kind of broke out of it. Kind of had to set him down and reacquaint him with reality at that point. But that was not on his medical form, and so that was a surprise to us, and it certainly changed some of our behavior and what we looked at when we walked with him in other hikes. The other one was more of the grand mal type situation. But luckily, this is another situation where the wife of the person was well aware of what the precursors to a seizure were.
Right.
When she noticed it, she immediately got him on the ground so he didn't fall, and then took care of him while he was down there. And again,
I love you're saying that, Ernie, because that's going to be our next step.
but then the thing is that once again, when he came back into awareness, he had to reacclimate himself to where he was and what was going on.
Yeah, very good. Sounds like you guys handled those really well. Can I ask a question? What was your adaptation for the person who had the sensory trigger from the flickering light?
I think what we tried to do in that is first of all, if we ever saw the existence of a strobe effect, I think one of the things we tried to do is maybe get people to block his vision, so that get a taller guy walking with him, so that he wouldn't have that strobing effect getting to him. I think at some point we tried caps, hats, but that didn't quite do it. One of the most things that we were most that we did mostly was to try and avoid the situation wherever it might occur.
Yeah. One thing I would have probably tried or suggested would have been the deep sensory sun blocking sunglasses. The kind that they use for folks who have had eye surgery. Those have a tendency to really stop a strobe effect from becoming a thing because they do block out a ton of ultraviolet. Video games can do this too. That's true. Yeah, video games are particularly bad because, all right, you guys are kind of getting my recreation philosophy stuff fired up here, but there's something that happens with respect to video games where we begin to focus only on solely one point, and so we lose periphery sensation. That's in people whose anatomy is functioning according to the book, like what we're supposed to be functioning. But if you watch TV more consistently and there's lots of rapid movement, but it's keeping you focused on one target, you do lose sensory and periphery stimulus awareness. And so that is part of this trigger as well, is that it's just super bad for you. But and I know it's ironic that we're on a Zoom call on a computer and I'm railing against technology. So there you go. But thanks for sharing that because you're absolutely right. Some video games can be triggers for folks as well. Okay, if there's nothing else right this second, we're going to get into first aid. So when we're looking at generalized onset with motor, we want to stay calm and somebody needs to track the time immediately. We do this when we're prepared. So what I would suggest to you is when you're getting ready to go on your trips as your checklist for your safety checklists, when you've identified somebody who may or may not have a seizure during the time, also identify somebody who's in charge of tracking time. That's their sole purpose. That's what their plan is. This should go into your seizure action plan, which we'll get into in a little bit, but this is one of those elements. Somebody should be identified as literally the stopwatch. That person's key job is to make sure that we have safety and that we react to prolonged seizure activity in the most medically effective way. The first thing that paramedics who arrive on the scene are going to ask you is how long. So again, if that person's keeping track of time, we're going to have that answer. That's going to dictate to them what kind of medical intervention they're going to proceed with. When nothing is evidenced to be in their mouth, we turn on side immediately. We want to protect a person from possible hazards, which means we look to the environment for anything that could be pulled down, knocked over, cause them to get stuck or injured. So even, in our environments, we're talking about sticks and rocks and pieces of equipment, possibly. And so we want to be able to get those things out of the way and out of, like 2 times out of the reach of where the person is having the seizure activity is what I would say. Cushion the head. Don't stop it or hold it. Don't restrict movement to the person who's having a seizure. That is very often the cause of additional injuries. So we're not restricting the body's effort to do electronic resets. We're just trying to make sure that a head is not banging against something hard, okay? And that we have some cushioning, something for the seizure activity to continue, but something to make it as safe as possible and no secondary harm. After the seizure, remain with the person until awareness is regained. This is a critical time for normalization, what Wolfensberger talks about with respect to a person is welcome, they're appreciated, they're valued in the group, and that this is just something that happened, just like anything is something that can happen, a bee sting, finding out you're allergic to that. I bring that up because it's a very personal example for me. I was working in a garden bed about 4 years ago, and I got stung by a bunch of ground bees who came up, and I was hooting mad, but no real bad side effects that day. And the next year I was working outside my garage, and sure enough, one little ground bee came up and stung me, and I was like, okay. I kept working, but then suddenly I started losing senses in my ears, and I started feeling swelling on my lips, and I was trying to talk to someone for help, but I was having a real hard time hearing them because the sensation had started to succeed with swelling. And I found out that I'm allergic to ground bees now, and that this can be something that is an onset in adulthood. And it may happen after you've had an incident where you've been stung before and nothing happened. So it changed my view a little bit about the idea of onset disability, and our awareness to be prepared to deal with it. Because here I am, a person who's been around disabilities for a very long time, knowing that things can change in life. And, I kept cleaning the garage for another 20 minutes as my hearing started to fade. But fortunately, I was able to get the medical intervention I needed quickly, and it didn't get a lot worse. So that's great. Focal onset with impaired awareness, we have to stay calm and reassure. And again, track that time. Track that time. Do not restrain. Again, that's where secondary injuries happen over and over. Gently direct away from hazards. So if you have to move or you can do things that are moving, I'm sorry, there's some sort of popping up, so I apologize for whatever noise that's making your presentation. Don't expect the student to obey verbal instructions, and stay close under fully alert and aware. Okay, so make sure that you're very close to the person until they're expressing their independence and expressing their autonomy. Encourage them to do so, but of course, just like they always say with great parents, be ever present and never seen, right? And so we try to get back to that scenario before we're moving on, so to speak. Okay, so the 3 basic principles, if you're going to beat anything home in the people that you're working with, if you're going to bring this into life and existence, you can talk about 3 basic principles. Stay with the individual, stay with that person. Be aware of their needs and be aware of the time. Okay. Stay safe in the environment, which means making sure that anything that could hurt them or you or anyone is removed from the environment while seizure activity is happening and after. And then again, side. So if you can, as much as you can, get folks on their side as long as they're not actively choking on something, because that's the best recovery position for the body. It's also the easiest place to cradle the head and make sure it's not banging on anything. And then of course, watch for that time. 5 minutes is a critical time. You gotta call for emergency after 5 minutes. Again, if PTAC or Scouts decides that 4 minutes is their go time for emergency care, that's what it is. If an individual has on their medical sheet and you have agreed to and are aware of the fact that they will have 5-minute seizures and that is common for that individual, you may choose at that point to go with parents' recommendation, or you may choose to just say, well, I understand that this is a situation for your child, but we have this policy and we're enforcing it. And again, that's above my pay grade to make happen, but it is definitely something that should be considered and talked about at every level of the scouting experience. So we have some seizure first aid posters, and you guys can get these for free from Epilepsy Foundation Greater Chicago. They're available in additional language beyond the English and Spanish versions, which you see before you. Note they highlight stay safe side, call 9 and when to call 911. And they also highlight the do not activities, do not restrain, do not put objects in their mouth. Can't stress how important that one is. And because medications can be given if prescribed by a healthcare professional and approved through BSA's policies for administering medications. That may vary depending on the medication. So be aware of who can and to what extent they've been given the permission to do so. Also, always make sure that the parent is on board with it. It's the kind of thing where they may say, yeah, go ahead, or whatever, but have that document signed that says, yep, we have that this policy and procedure in place with respect to this child's care. It's important. Ernie?
Hey, Michael,
Mike,
I have a
it looks
question.
like Ann has a question.
Oh, go ahead, Ann.
Yeah, so my son at one point was prescribed a medication that needed to be given through the bottom as like it'll supposed to help break them out of a seizure.
Yep.
If those those scouts are prescribed that, are we allowed to administer that?
Allowed, yes. Recommended, not so much. The nasal sprays are a newer and as effective, if not more effective. So I would definitely say check with doc, see if that's something that we can pivot to, because that's a lot less invasive. Also, you should identify exactly who and make sure that the doctor signed off on, yes, they're trained to do this correctly. I'd be thorough with your medical documentation of who's administering care, because that is one that Epilepsy Foundation, they just updated their slides this year. We used to cover that the last couple of years. And that's one where they're like, go to the nasal spray, get away from this. Let's not be telling people that they're responsible for using that particular intervention, even if it's the most effective intervention for the individual. Also recommend that folks look at, hey, nasal sprays have come a long way, baby. Maybe that's a good opportunity to change. It's just a lot less invasive. Any other questions or follow-ups? And thanks for asking that question. I trusted that there would be somebody in this group who was aware of that and would bring that up. Okay, so let's talk about convulsive seizure in a wheelchair. This is something that I've had a lot of experience with. When I first started working with people with disabilities, I worked at a place called the Helping Hand, and it's in Countryside, Illinois. And I worked with a segregated population in a classroom setting where there were 18 individuals. About 9 of them were in wheelchairs and were wheelchair users, and probably had 7 people with seizure disorder in that room. So seizures were a common daily experience, and chairs were involved in those scenarios. So I've had a lot of experience with it. Do not remove the person from the wheelchair unless it's absolutely necessary. The wheelchair is usually the safest place. It's the place where they have comfort, familiarity, where their body may be conforming, their body articulation may be conforming to the foam padding for the chair. And so taking them out of the chair might actually risk more harm, depending on the status of their spinal anatomy. Ensure that breathing is unobstructed and allows secretions to flow from the mouth. So go ahead and let whatever's coming out continue to come out. That's perfectly fine and recommended. Fasten the seatbelt loosely. In other words, don't crank it down to prevent the person from falling from the wheelchair. If you really crank down someone's chair, a seatbelt in their chair, it becomes completely an extension of themselves and is subject to imbalances with more dramatic movement. Protect and support the head. Again, we bring this up over and over again in seizures. Supporting that head, keeping the damage limited to the electro currents and not necessarily to the banging that may occur when somebody is in a full convulsive state. Secure the wheelchair to prevent movement. In other words, don't let the wheelchair keep rocking around or moving without locking it in place. And if you can stabilize the wheelchair to keep it its base secured rather than tilting, that's always the best strategy. When we talk about public transportation for any seizure, what we want to do is check for that medical ID bracelet if possible prior to. Um, The first car is dedicated to anyone with disability or needing assistance in the CTA and Metro system. In your scenario where you guys are caravanning to a location, you might want to think about that being part of how you're going to organize yourselves. And you might not necessarily do that actively telling everybody and disclosing, well, this person's going in this order because kiddo X has epilepsy and we need to make sure that they're at the front of the line so that everybody can follow along in the correct caravan orientation. Just plan it, do it, move them into position, and let's not draw additional attention to that, but let's be aware of it as leaders, is my recommendation. When seizure activity does occur and you are driving, the driver should pull over. And it doesn't say it here, but being a person who holds a CDL and commonly drives a 24 to 26 passenger vehicle, you want to pull over to the safest spot, not just a safe spot, but the safest spot that you possibly can. Obviously, there's some spots that are less preferred, but you got to make sure that you're completely and totally away from where traffic could be bad or just a little off. Someone's on their cell phone and they can sideswipe, and that's a bad thing. We're all very aware of that these days. So just make sure it's the safest spot that you can locate very quickly. Place the person on their side or in the aisle, and then follow your seizure action plan, which we're about to go over and do in just a moment. Medical emergencies, the status epilepticus is to continuous state of seizure activity. We're looking at prolonged seizures or repeated seizures without regaining consciousness in between. These are our medical emergencies. We've got to have additional resources in the medical profession who are out to help us. Every time if you have somebody who's never been diagnosed with epilepsy, never experienced epilepsy, and they're having a first-time seizure, this is a medical emergency. You call the professionals immediately. We don't just have someone have a seizure and go, wow, that was weird. Gotta go get medical attention right away. They're gonna want an EEG. They're gonna want to start the diagnosis process. It's really, really, really important. More seizures than usual or a change in the type of seizure that they commonly experience is a medical emergency. If you're having some acceleration in your seizure symptomology, that may mean that there are secondary factors, and we need to medically have those identified in order to advocate for the child or adult who is experiencing seizure activities. Convulsing seizure lasting more than 5 minutes. Again, this 5-minute mark is the recommended Epilepsy Foundation CDC guideline. If you want to go 4 minutes, feel free. That's a choice that you make as leaders. I might add, is mostly volunteer leaders in a community. And that's something that I think BSA would have to weigh in on. If the seizure occurs near water, in water, that's also a medical emergency. We don't know the exact amount of effective water that might be aspirated into lungs. Aspirated is a kind of a fancy word of saying, hey, water got into your lungs. The effects of that might come just a little bit later. It may not be the kind of thing where, wow, now they're drowning right now. It might come later in the way of infection. It might come later in the way of coughing or shortness of breath during a different activity. And we certainly don't want that to be the case. We want to be very aware that the person was in the water and they had a seizure, and we have no idea to what extent the secondary factor, the water, may have created some opportunity for future injury. Okay. And then follow your seizure action plan. So possible seizure triggers, factors that might increase the likelihood of seizure in a person with epilepsy. Missed or late medication. This is where you, as leaders in your various groups, are super duper important to the process, because the kids get very involved in some of the activities and parents get involved in activities if they're along with you. And sometimes things start to slip. So whoever's on the trip and is medically responsible, you must make sure that that medication is absolutely happening and happening on time. Because missed and late medication is the #1 reason why we see a trigger for seizure activity. Overheating and overexertion, again, it's another risk factor in scouts. So as long as you guys are making sure that all the kiddos are getting enough, enough rest, not to overheat or overexert, but still having a good time, that's always a good plan. Stress, anxiety, lack of sleep, of course, sometimes accompanies some of what we do. Poor diet and missed meals, never had that at a PTAC event. Hormonal changes, obviously that's individual by individual, but at some point, some of our folks are gonna experience that. Alcohol and drug interactions, hyperventilation, and of course, flashing lights, which we've talked about before, right, Ann? And that's all part of what we need to be aware of as we go through this. In many cases, there is no identifiable trigger, so don't look at this list as an exhaustive one. Look at it as the ones that we absolutely know we can control. Additional triggers are going to be individual by individual, and that's why we put together a seizure action plan. Anti-seizure medication, what you need to know, 70% of seizures are controlled on medication. Okay, so 7 out of 10 folks who have epilepsy are going to have a very good strategic plan for not having a seizure that involves medication. So, but there can be side effects, so we need to be aware of that. Double vision, sedation, dizziness, weight gain, irritability, inattention, other motor function impairments. Some personality changes may happen, reduced intellectual functioning, all may happen because of seizure activity. I really need to put my disability studies hat on for a second. And this is where we as leaders really need to tap into our empathy and our affect and identify with the individual who's maybe on a new medication or experiencing some of these side effects and try and talk about that openly and give them a forum to express their uncertainty, their frustration, or their needs, and feel supported by how we're going to help them manage that and still have a great experience. I think a lot of the times we begin as people who are going to coach up or lead or go and create an activity or an experience that we idealize. Certainly making adjustments along the way is part of what we try to do, but we might get a little so distracted by the activity and how it's going and whether or not it's effective that we forget about maybe some of the underlying anxiety that someone who is not mature enough to express those anxieties, but also may have these personality changes or reduced intellectual functioning to be able to identify them. So we need to be very aware of the ecology of their symptoms and the side effects, how it's affecting them, who it affects them around, because that's all part of individual care. So, all right, take that hat off. But always keep their emotional needs in your mind, please. Medication depends on seizure type, and what is right for that person is right for that person and only that person, especially dosage wise. So it's not appropriate to ever give somebody a different dose or a different medication than they usually take. That may actually cause seizure. That would be a real big no-no and not real good for us. So don't do that. Only prescribe medications in the appropriate doses at the appropriate times, please. And there's more than 20 types. So Epidiolex is FDA approved. It's a marijuana strain rich in cannabidiol or CBD, a non-psychoactive compound of cannabis, again, non-psychoactive. It's delivered as oil suspension and ingested. There's no set dosing schedule or contraindications, and it's wholly available. CBD can be dosed with medication in some patients, so be aware, again, no exchanging this particular medication with anybody else's medication. And again, not one size fits all. Every individual has their own prescriptive amount of these FDA approved interventions. There are palliative treatments, which are part of the vernacular, the background of what's happening with epilepsy. The vagus nerve stimulus, or VNS, is generated an electrical pulse program rate automatically and continuously 24 hours a day. This is a device. So as with any device, we need to be aware of its care and maintenance. So please take the time to invest the time with the parent and the individual who has a VNS system to talk about maybe some things they need to be aware of. Because let's say you're going rock climbing in a particularly rocky place in some slippery terrain. We need to be aware of how we're going to protect that particular thing so as to make sure it doesn't get damaged or there isn't an issue. Responsive neurostimulation therapy monitors, detects, responds to seizure activity. There's epilepsy surgery. So it's a laser ablation, rewire neural networks, and can be curative. But again, not everybody is, seizure activity presents the same, and not everybody is, it's not a one trick silver bullets type situation. It may not work for a large majority of people, but it does work for some. Ketogenic diet, again, here's a palliative treatment that basically is oriented to one type of seizure trigger. That special high-fat diet is used for difficult to treat seizures. Diet eliminates sweets such as candy, cookies, desserts. This is oftentimes something that we need to plan ahead of in meal planning, be aware of for an individual, also be aware of with respect to those commensurate temptations that come from being around our friends and all of them having the candy, but we can't, et cetera, et cetera. Those peer pressure moments. You know, we need to make that conversation open and available, and talk to other campers who are going to be with the camper who has the special diet and say, how can you be supportive? How can we talk about why it is that their diet is this way? And let's be protective of each other, and have that be, you know, a team building type of concept that revolves around the ecology of the person with the seizure activity. Rescue medication. Now we're talking about that diastat and the rectal administration. The FDA approved gel form of Valium, and for patients 2 years and up who experience seizure, cluster seizures and breakthrough seizures. Again, moving more towards the nasal seizures is kind of where we're going as a field and in the science, but this is definitely a rescue medication. If you're really in the need for rescue medication, you probably should have called the medical professionals who would typically administer this and have them do it. So that's where we recommend the chain of medical intervention take place. Intranasal, again, the midazolam and diazolam are part of that intranasal spray. It's a form of Valium, again, best for cluster seizures. So those seizures that you're having in successions. The efficacy is similar to diazepam. The comfort level is greater, especially for teens and adults. And so again, we recommend that move to intranasal sprays, if at all possible. Medical professionals are the ones who prescribe. Medical professionals are the ones who tell us how we're best applying medical interventions. So it's up to them, but parent advocates can certainly have some discussion around that, and hopefully it becomes the best solution. Valdeco is, again, a diazepam nasal spray, again, for cluster seizures and comfort levels greater, especially in teens and adults. So let's get to the most important part and the last part of what I'm going to talk about, which is the seizure action plan. And we can get copies of this from Epilepsy Foundation out to you leaders, and then you are free to copy it as much as possible. I would suggest even running a scenario where you're making up somebody who has some of these seizure action plans and going through a scenario with your group leaders and saying, this is how we have to fill out this information. This is why it's important. You have your basic intervention or your basic emergent contact information at the top. The medical history, if there's additional things that may be triggering, that's a good place to start. Seizure information, the type of seizure, length, frequency, and description. Can't stress that this is not a place to be short. This is a place to be very specific, but as descriptive as you think is possible. So don't allow this section to go blank from a parent or guardian who's filling it out. And if you ever have to fill it out because of a date that you experienced the seizure and you were kind of doing the after incident report, you fill out a new seizure action plan based on that report, and this will help cue you to what should go in there. Again, the person who was keeping track of the time, you talked about the frequency of seizure activity that you saw. You describe it in great detail. It's all part of a good follow-up seizure action plan. So a supplement to what you're planning ahead. Basic first aid and care that was given and what you chose to do. The emergency response and the protocols that are typical for the individual are listed there in that middle section. And then, of course, treatment protocol during school hours, or in our case, activity hours, including the daily and emergency medications. So you want to see those listed there. You want to see those detailed in how the administration and maybe even who administers. Maybe you change the seizure action plan slightly per trip. So if you're going to go on an overnight and the person who typically is doing medical intervention and medical awareness for the group is not available that weekend, maybe do a new seizure action plan to identify that specifically for that trip. Probably a good idea. I really like the idea of not being married to one. We just did the seizure action plan once a year, and that's good enough. Do it for long activities. Make sure you're going through the process. It's great for orienting new leaders. It's great for reorienting and reminding old leaders who haven't experienced it, or folks who have experienced it and do know exactly what to do. It's good rehearsal for if they do see the symptoms again. Special considerations and precautions regarding activities or sports or trips. That's a good place to identify different activities that you're going to do where an occurrence of seizure activities may have secondary risk factors. And so you'd fill out those things right there. That might help you identify which adult or which leader is going to be doing which job in that certain scenario, because you may split out groups and the person who would typically be in charge of timing it might not necessarily always tag along with that group who has the person who has seizure activity with them. Because we do shift a little bit in some of our groups and our supervision. So let's be aware of that. Let's plan ahead on that kind of stuff and, use the action plan, use the action plan, use the action plan. And again, free copies of this are available through Epilepsy Foundation. Post-training, you guys are going to get a Seizure Smart partner decal, and we'll take the total attendance, and I'll put Ernie in charge of making sure those get distributed because he's the most responsible adult that I know. And I think if anybody has any other questions or comments, I'm just including here at the end additional free services that Epilepsy Foundation has, the education on school personnel, community seizure first aid training, advocacy for Seizure Smart School, Camp Black Hawk, and of course, medical bracelets available to clients if necessary or needed. Epilepsy Foundation is a great resource for all of those things. Aisha Akhtar can be contacted and is amazing at getting back to you and an incredible advocate. And she's running a foundation fundraiser, in London in a half marathon because she's pretty much a superwoman. So great woman to know, great woman to call. Please feel free. She's got tons of resources, and I'm okay at answering some questions and helping out too. So feel free to contact me anytime. I'll put my information in the chat, and let's talk a little bit. And what you got?
Okay, sorry, the dog's barking. So when we have restrictions for an individual that cannot go into the water, how can we modify some of those like swimming activities?
Yeah, so that's a great question. What I'd like to do is look at which activities you're selecting first. And then look at whatever additional devices might be helpful for that person. So in recreation, we talk about 3 different kinds of modifications for any given activity. You modify rules, you modify setting, and you modify actions or responsibilities within the game itself. And so I would take an analytic look at exactly how you're using the environment you're using and why, and then what the activity is. So can you give me an example of like the activity that you want to modify?
So when my kids went to summer camp, they had to pass a swimming test.
Mhm.
Even though the kid that went doesn't have the seizure disorder, I'm just kind of like thinking proactively. My oldest has a seizure disorder. And so far he's never had any restrictions, but my son's seizures right now are controlled with medication. So I was just kind of wondering, you know, any tips on anything if somebody does have restrictions with being in the pool.
Yeah, it's really a matter of what adaptations you can come up with individual by individual. It's really good to reach out to professionals who are, again, therapeutic rec folks are great about that, including myself. So if you have an activity that you want to do and you say this person has these characteristics as an individual with disabilities, they have these restrictive needs, how can we change the nature of the activity so that everybody continues to enjoy it, and we look case by case. I don't want to be the person who says, oh, well, let's brainstorm for the next 2.5 hours on all the different types of disability. And we're going to, I can do that with you separately. And I'm willing to do that with anybody who wants to bend my ear about that. I love talking adaptations. But again, follow Brofenbrenner's idea that there's an ecology around every one of us, that there's a way that we interact with all of the levels of our environment and that we are in control of changing those interactions. And so we have to think in those terms rather than just the environment is static and we have to adapt to intervening with it. I know that's an answer, non-answer, but please do feel free to call me anytime about, Mike, we're going to do this, you know, kayaking, and I've got somebody who definitely can't, or whatever it is. And we'll try and find some solutions. Other folks, other questions? Anne, go ahead.
Sorry, guys. So the last time my son had his grand mal seizures, I was video recording it. And I was able to send it right to the doctor.
Great.
So for him, it worked out great. Is that something that we could do for the scouts?
If you get permission, again, parents are got to give permission for that type of information to be disseminated, shared. Also, you probably want to consider, I'm giving information about other kids who may be in the video shot. You know, that's the kind of thing where it's like, okay, well, we did this for this purpose for this one individual, and the parents are behind it and the individuals behind it. That's the other thing, guys. Honest to God, again, my disability studies hat comes back out. It's great to get permission from parents on stuff, But really, if you want to advocate for an individual, you have to allow them to self-advocate for themselves. Ask them the question, is this okay with you first? Is this something that you consider the best of your own medical attention, and you're owning your medical state and the interventions that you want? Give the kids the chance to be aware of how much autonomy that they hold, and that they're responsible for their bodies and themselves. And they should not feel ashamed of it. They should feel in control of it, because having a seizure is not something you feel really in control of a lot of. So at least having control of what's going to happen when I don't have consciousness, or what's going to happen when I don't have full control, gives that person some autonomy back. And can't stress enough that they're important to be including in part of that. And sometimes as parents and sometimes as leaders, we roll right over people's autonomy because we're just trying to get the whole group to go. But this is one of those instances where it's just a little bit more important to make sure that we're respecting that. And I know you guys are all great leaders, so I know that that's not something that's hurting your pride or affecting you negatively. So thank you for considering that. Yeah, Jennifer. You're on mute. Can someone help? Oh, still can't hear her. I think perhaps she has to be unmuted. Nope, can't.
It looks like from a tech side, she is unmuted. From a Zoom side, that's all. Nope, now she's. Let's see if we could try to help here.
And Jennifer,
Jennifer, can you put it in the chat room?
Yeah, that's what I was going to say.
Good call.
Someone smarter than me.
No.
Or hear me.
Hey, here we go.
Okay, we're actually in the same room.
Oh,
So I'm going to have her talk through my computer.
great.
Since we're together. Oh, great. Can you hear me?
I can.
Okay. So we have a scout that just crossed over, and seizures have just started to begin happening last March and April.
Were these the first seizures that they've ever happened, or the first ones that they've experienced in scouting?
No, this was the first time they were ever happening. So this is new to the family, new to us. Would you recommend having the parent or the scout talk over with the troop if they feel comfortable about
Yep.
because we're thinking, mom's like, well, he's having a majority of them when he's sleeping. Well, if you're sleeping with a buddy,
Yep.
all of a sudden you're having a seizure in the middle of the night. So this is one of the things that maybe it should be discussed as a troop and not total confidentiality, because this can affect him and everybody else around him as well.
Sure, absolutely. Look, if I were allergic to berries, and somebody just thought it was a big funny joke to put berries in my oatmeal or something like that, and I didn't notice and I had them, and all of a sudden I had a problem, it's good to make people aware of like what's not funny and what's a health risk, and how to best advocate for each other and make sure that we're keeping each other safe. We can have fun, we can be rough and tumble, we can do all the things that we want to do and learning about adventuring out in the world, but we should do that with a concern for our own safety and the safety of our environment, because that's what we do, right? And having that person be their best self-advocate is the autonomy building bricks that allow the person to feel more confident about continuing to take adventures and enjoy adventures. When you start restricting those things or taking them away or talking over, those are the first steps away from the adventure.
Okay, and then one last thing, the seizure action plan. When you say, go over it quite often, especially if there's, longer adventures that the troop's doing, do you have to have the doctor sign each one?
No.
Okay.
No. That's what I'm saying is, a doctor may sign off on the general seizure action plan for health intervention.
Okay.
But you're going to use it as a tool for planning.
Okay.
So, you've got your master document, right? And that's on the kiddos file in your medical book that you're carrying around because you are really responsible adults. And then for that trip, you plan, okay, well, during this part of the time, we're going to make sure that we're aware of these risk factors. During this part of the time, we'll be aware of this risk factors. Who's the adult who's going to be in charge of that particular group that the person's during this part? Okay, well, let's make sure they're aware and know what to do and who has what role. And then the next one, who's aware and who has what role, et cetera, et cetera. That's why going through it, it just takes a little bit of time. It seems like, wow, Mike, that's pretty tedious, but this is what we do with our folks when we go on trips for special rec. I'm a director of a special recreation association. And when we go on long trips, we literally go activity by activity through whatever length scenario, whether it's a weekend or a 7-day trip, and say, okay, well, this is what we're doing, who we're calling, where we're going. If we have a seizure and we happen to be in Boston and we're doing a whale watching tour, we got to know where to call and who to call.
Okay.
We can't depend on other people to react perfectly.
So we write, he's got his main one, but then we write ones up.
Yeah, you write your supplemental plan for activities and activity transitions.
All right, perfect. Thank you so much.
Thanks.
I've got a quick question, Mike. Are there any types of seizures that are not epileptic?
No.
Okay. That answers that question.
Well, even medically induced or insulin related ones are still under the umbrella of what is epilepsy. Look, just because your insulin levels change chemically, it's still causing the same effect. Epilepsy is a storm in the brain.
Okay. Okay.
So we get into like whether we're name calling something as if we're creating an identity for it. Don't think about it like that. Think about it as like it's epilepsy. If the person's insulin is going to get down to a level that's this, they're going to experience these behaviors. Whereas other people, if your insulin gets down that low, maybe you just get sleepy, or maybe you just get hangry. I know a lot of you have probably been very hangry at some points. Roger, I'm looking right at you. You look like you look like you're hangry now. Anybody else? Comments, questions, concerns?
I just appreciate the information, Mike. Nighttime, I'm a scout master, daytime special ed teacher's assistant at Schaumburg High School.
Hey, all right.
You gave us more in the last hour than I've gotten in the last 2 years.
I'm sorry to hear that, but
Yeah,
but you know what? If your district wants me to talk to them too, just let me know. We'll set up a
there won't be
meeting.
a call.
Okay. Aisha will be so happy.
Hey, Mike.
Yeah.
This is Bertha. Can you send some of those seizure action plan forms to Ernie?
Yeah, I'll try. Yeah,
Or send it to each one of us, or?
I'll try and get it to the PDF to Ernie so that he can disseminate it through the email chain that is created through the registration.
All right. I like to keep one in my first aid bag or something.
That sounds awesome. And
Yeah.
if you're going to keep one, keep 10.
Yeah, exactly. Yeah, if I get one, I'll make copies. That's all I need.
Yeah.
Thank you.
God
It was
bless
a
us
great
all.
presentation.
Thank you. God bless us all. And I really hope that we don't experience it. But again, everybody has a first seizure.
Yeah.
If you have that plan in place right away, you're going to give the medical professionals a lot of good information that they can work with to help with diagnosis in the beginning of the treatment management plan for that individual. And I can't think of a better way to protect people than to really advocate for their health and advocate for the path they're taking down autonomy in their own health. And that's the gift that we have that we can give to somebody who's going to experience this for the first time. So obviously I take this stuff to heart and very personally. So I hope you will too.
Thank you for everything.
Yeah. Okay. Well, everybody have a great night. I will stop interrupting your meeting and wish you all the best. And I look forward to maybe talking to some other folks sometime soon. Please do feel free to reach out. I am always here for answering questions.
Thank you.
All right.
Wow.
Thank you. This is awesome.
No
Good,
problem.
good session, Chris. Thanks for pulling it together.
No, honestly, a huge credit to Ernie for putting it, but Mike, I have to say, obviously we focused on advancement and recognition, and this was certainly the most I've ever learned. This is so cool. Thank you, Mike. This is awesome.
No problem. And Ernie is the man, isn't he? Let's get that.
Yes, very much so.
I'm just a pencil pusher. One of the things we used to have in the old wood badge was to know your resources. And I think I've been very lucky to meet Mike and to learn how great a resource he can be in all of our endeavors. So I really appreciate what you did tonight. I think that from my perspective, this was a fantastic presentation. And, I've really learned a lot. I thank you again for doing it.
Problem. Hey, as you guys are going back, one last pitch, just as an aside, think about doing Greater Maywood Paddle Program. Free access to kayaks and PFDs. And I know somebody who can help be a leader of an activity. So let me know if you're ever interested in that. They can take up to 20 people at a time. Pretty cool.
What's it called again? Greater Maywood?
Paddle program.
Okay.
It's a great free access to resources that's local to Chicagoland area that lets you take a nice, safe little paddle to orient our folks to maybe bigger and more adventuresome things.
All right. Thank you.
All right, hopping off. Thanks, guys.
Have a good one.
Have a great night.
A big thank you to Mike. Big thank you to Ernie. Any final thoughts, Ernie, that you wanted to share from the Special Needs Committee?
Well, I think I'm really excited about the new year that we're coming into. I don't call it a special needs committee anymore. I call it a special needs community. We have a number of people who are professionals like Mike. We have other people who are parents of special needs scouts that have come through the program and may have even achieved Eagle by this time. And we have a number of people who are just starting with their child in the Scout program. And I think all of those people coming together in various levels of participation make us a community. We have people who don't have the time to attend our meetings, but do want to receive the information, do want to be available, and are available if we need them to speak to other people. We have other folks who are working to definitely raise awareness and to make sure that people understand that scouting is for all, and that anything that a so-called normal scout can do, we can adapt for someone who has special needs, so that an excellent program can be provided for all youth. So I think it's important that word gets out. I think that word is getting out. And we have a number of people sitting right here who are members of that community. We've got Bill Egan and Tom Wetzel and Pence, Bertha Guzman, Olivia Patch. Those are all people who are part of that community. And anybody else who is here who wants to be a part of that community, let me know.
Well, I couldn't have said it better myself, and I love the way that that new title of community, because that's certainly what we all are. So it's great to be a part of that and supporting the special needs movement. And I'm very, very grateful for you being a part of our advancement community and really appreciate you and Mike and the entire team. We benefit from having the Leahys and as well as Tom Wetzel on our community. I like using that now, and we're just so grateful. So thank you, everybody. Appreciate you being here. Think about us every third Thursday of the month where we have a different topic. Next month's topic going to be very relevant for those that are Life Scouts. It's the Life to Eagle seminar. So please join us then. And until then, stay very safe.
Thank you.
All right.
Take care, everybody.
Good night. Bye-bye.